Welcome to webinar number 6, I believe it is. This is David Rawson, President and Founder of the Canadian Academy of Clinical Sleep Disorders Disciplines. Thank you for joining us tonight on the first night of NHL hockey in Canada. There's where the audience went, John. They're down at the garden. They're watching hockey. So just a couple of quick housekeeping announcements for you folks. First of all, thank you for your patience. The last webinar we had, it was a disaster. I tried to do everything at once and it didn't work. I'm now at my office where my download speed is 98. I could download a 4K movie in no time. So here's the deal. I want to introduce, first of all, our newest employee, Bianca Calla, who's our Director of Communication. She just waved to you. She's the lady who's going to make this thing look like it should have done years ago. We actually have a YouTube channel, and Bianca might speak to that at maybe question and answer period if there's any questions. But essentially, every webinar we've had will be up in its entirety on YouTube. It'll be partitioned from the presentation, and then we have a separate file for questions and answers. We also will be sending out to everyone the PDF of the lecture itself through the website. And the most exciting thing that I don't even understand is Bianca understands a thing called social media. We've had accounts in the past that we only use to try and drive attendees to our meeting. Clearly, we're not having another meeting this year. So she is the gal who's figuring out how to interconnect it all. And eventually it's going to lead back to our website and to YouTube. So my plea to any of you who actually use Facebook and all of those things that make me crazy, please like and share every time you get a post regarding us. This is going to be an exponential growth, hopefully an exponential growth venture where before we were just stuck in the corner. So if you're on your phones and you do Instagram or Twitter or whatever, please like and share. We'll talk about more of it next or at the end of it before our question and answer, but I do not want to waste our speakers' time. So as you know, you're here to hear the one and only Dr. John Viviano of Toronto speaking on CPAP or oral appliances, which is better. What they didn't teach you in dental school, which in my world is everything. We didn't learn anything about TMJ and sleep. So, and I know most of you from looking at the screens, you've been doing this for a long time. So John is going to take it over in a few minutes. You need to know that John's a humble man and he won't want me to brag about him, but I will. He had the first clinic in Canada to be certified by the ABDSM. That's a huge accomplishment. As you know, he has his own standalone clinic now where he treats and teaches in Toronto. And it's just a wonderful opportunity to have John share with us tonight. So without any further ado, other than Bianca, who I just introduced you, is controlling the mics. Everybody is muted as of now, and we'll unmute when it comes to questions and answers. So save your questions technically, save your questions for the Academy. And I will now like to turn it over to Dr. John Viviano speaking on CPAP versus oral appliance, which is better. Thank you, John.
Thank you very much, David. And thank you everyone for joining us tonight. Appreciate it. CPAP versus oral appliance therapy, which is better? First, I just need to confirm that you see my full slide and you can hear me clearly. Everything's good? Okay.
Yes.
Yes.
So of course, the next thing is, will the advancer work? And so let's see here. So that's not working. So there we go. We'll do it manually. So this is my office, and we have a CE center there, seats 30, have a lot of fun. So hopefully, I think many of you actually that are on tonight have been there at one or two programs. So it's a place to go in Toronto if you want to spend some time talking about dental sleep medicine. No vested interest in any appliance, device, or technology. I maintain a sleep disorders dentistry practice. I involved in research to some extent and provide educational programs. The facility is accredited by the ABDSM. And why that's important is that basically everything I do at my clinic and everything that I teach in my programs is 100% in alignment with the American Academy of Dental Sleep Medicine. And the only reason that's important is from the point of view of our CDSO here in Ontario. If you don't want to have to worry about getting a phone call from them, just follow the ABDSM guidelines. It's as simple as that. Has nothing to do with whether I agree with everything that the ABDSM says. It's just the safest place to be. Now, objectives today, how CPAP and oral appliance therapy compare regarding both efficacy and compliance, how differences impact on commonly measured therapeutic outcomes, most important factor influencing which is best, and it gives it the best therapeutic alternative for a patient, right? Which is the best. And of course, all this information will help us have tools to deal with physician resistance. Now, the objective of what I'm sharing today is to help foster collaboration and mutual respect. But typically, physicians seeing this information would really rather be fantasizing about seeing me and my team burning over an open fire in the parking lot. And that's just the reality that we face, even after all these years of mounting evidence about oral appliance therapy. So CPAP on the face or oral appliance in the mouth, which is better? That depends on your optics. So we'll discuss that. And we'll also talk about what the most important factor is, but we'll be circling back to that at the end. Okay, so some background here. This is a deep dive market analysis by ResMed. 30% referred for sleep studies don't get tested. 82% would be positive. 50% give the reason, I don't want to use CPAP. Okay, almost 1 million CPAP non-compliant yearly in the US. Many unaware of alternative options like AutoPAP, oral appliance therapy, combination therapy, or some surgeries, etc. Okay. This is a deep dive or a market analysis by SomnoMed based on information from their current fiscal year, 2020. About 2.5 million sleep studies conducted in these 22 countries. Now, they say, or they estimate that that's down about 500,000 because of COVID. 1.9 million proceeded with therapy, 1.35 million on CPAP, not a surprise. About 700,000, approximately half, 52% dropped out after a year. Oral appliances, 350,000, about 28,000 dropped out after a year, about 8%. 200,000 went on to surgery, lifestyle, etc. Question, what happened with the 700,000 non-CPAP compliant patients? Well, clearly they're not ending up in an oral appliance, so they're just falling through the cracks. 2016 Frost & Sullivan report, I'm sure many of you have seen, 5.9 million diagnosed in the US as of that year, and 60% remain compliant with CPAP. Well, that's a 2 thumbs up for the physicians, because 60% compliance, that's pretty good, by many people's standards. Now, the reason cited for non-compliance is discomfort and inconvenience of CPAP. Interesting, similar to the reason that people weren't even going for sleep studies in the first place, according to the ResMed deep dive, was they didn't want to wear CPAP. So why even bother going for a sleep study? Okay. At least we're helping 60%, which is typically, the mindset. However, that same year, McAvoy publishes a study, almost 3,000 cardiovascular patients. Half of them were in CPAP, half of them just using usual and customary protocols and advice and guidance. 7-year follow-up, there was no difference in cardiovascular mortality and cardiovascular incidence over the 7 years between the two groups. So how could it be that CPAP was not providing them any protection, right? Well, when they looked, the compliance was about 3.3 hours per night. Comprehensive systematic literature review, 20 years of data, the rate of CPAP adherence remains persistently low. So it's not new news. They know that CPAP is pretty adhered to and that these are the compliance. Why is this okay? I had a hard time for the longest time understanding the CPAP bias. Well, there's a reason for it. When we look at prescriptions in general in medicine, only 25 to 30% are taken as prescribed. So, the fact that 60% of patients are adhering to CPAP at some degree is pretty darn good. That's worthy of giving you a pat on the back. When 25 to 30% is the standard. There's things like hypertension meds and asthma meds. They are used like 25%, 12%, 15% of the time as properly as prescribed. So, they're not doing so bad when you look at it from that perspective. And on top of that, there's very few things in medicine that will work as well as CPAP. When you look at all the different therapies that are available, that are prescribed in medicine, there's very few things that have virtually 100% success rate. That virtually 100% of the time, they're going to be able to reduce that apnea down below 5. Using that criteria as a success, right? So when you look at oral appliances versus CPAP, let's put it on the table right off the bat, right from the beginning. CPAP is superior. This is a meta-analysis over several studies. Here you can see that CPAP is kicking ass and much better than oral appliances and eliminating the apnea. However, when we look at objective health outcomes, similar objective measurements of sleepiness, psychomotor speed, driving, simulator performance, cardiovascular system outcomes, and mortality, similar. Okay? When we're looking at functional outcomes, snoring, sleepiness, neurocognitive function, quality of life, mood, similar. Now, snoring oral appliances don't do as well as CPAP, but quality of life oral appliances do better than CPAP. Nevertheless, overall, similar. Okay? Blood pressure outcomes, similar. We look at cardiovascular mortality risk. This is in the Anandan study, similar CPAP to oral appliance therapy. Okay? Now, interesting here, they were losing fatal events as the indicator for a negative outcome. When we look at the residual AHI with oral appliances, it was 16 events per hour. Residual AHI with the CPAP was 4.5. So even though the apnea was brought down to 16 in the oral appliance group, similar outcome with regards to cardiovascular risk. The other thing that's interesting is the treatment usage. Oral appliances, 6.5 hours a night. CPAP in this particular study was 5.8 hours a night. So even though it's higher, 5.8, than the traditional minimum of 4 that we know, it still didn't fare better than oral appliance therapy with regards to preventing cardiovascular incidences that are fatal outcomes. Okay. So how do we explain this? More effective, but similar outcomes. Well, there seems to be a dose-response relationship between hours of CPAP use and the range of subjective and objective health outcomes. When we look here, cardiovascular events, right, that 4-hour mark, you can see, the two groups developing. You see development of hypertension, that 4-hour, greater or less than 4 hours, there's two groups developing, two distinct groups. Measurements of sleepiness, functional outcomes, questionnaires, Epworth sleepiness score questionnaires, multiple sleep latency scores. You can see the dose relationship. Performance is based on how many hours they're using the CPAP, okay? Patient using CPAP less than 4 hours per night were 5.1 times more likely to develop severe hypertension. Treatment compliance, on the other hand, favors oral appliance therapy. You can see very clearly here, this meta-analysis shows that oral appliances kick ass in this category. Even with strategies to enhance patient acceptance and usage, only about 50% of patients use PAP greater than 4 hours per night after about 6 months. As a matter of fact, oral appliances being adhered to more often than CPAP was one of the reasons that the 2015 guidelines have oral appliances indicated as a standard of care for mild, moderate, or severe sleep apnea, if the patient simply prefers it, or of course, if the patient is intolerant to CPAP. It was because of the high compliance associated, realizing that if the patient strongly prefers a treatment and they'll actually adhere to it, it's better to do that than to ignore that request on the patient's part. Risk of side effects resulting in the discontinuation of oral appliance therapy is less than those resulting in the discontinuation of CPAP. Oral appliance had fewer side effects and greater patient satisfaction. This is out of the Ramar, paper, which is basically the 2015 guidelines. It's the findings that they had after reviewing all the literature as of that point. When we look at preference, you can see right across the board over all the different categories. I don't have to read them, they're right there for you. About 20% of the time, CPAP is preferred. About 80% of the time, oral appliances are preferred in a scoring. So patients preferred the MAD to CPAP in all aspects on an 80 to 20 scale. When we look at patient preference from the data on crossover studies and parallel studies, there's a number of them that have been done. And those that actually reported patient preference right across the board demonstrate that oral appliances were preferred. There was one that CPAP was the preferred therapy by the patients that participated. But when we look at the appliances that they used for that study, they were fixed appliances. So let's jack the patient forward 80% of their range, and let's fix them in that position. And then let's test and see what happens and see how well they like that. Well, I don't know. I've been doing this a few years, and I can tell you that there's very few patients that will like that right off the bat. Maybe they might be able to get used to it with time, but within the time frame that they were doing this study, I would have probably chosen CPAP myself. That's just not the way. That is not typical of the way oral appliance therapy is conducted. So I think we need to exclude that Engelman study altogether, because it's just not representative of the way oral appliance therapy is provided today. We're still in this COVID environment, and clearly it's not going away anytime soon. What are the benefits of oral appliance versus PAP? Well, we've heard about this. Reduces the likelihood of contaminating the surroundings with viral-laden aerosol. CPAP masks leak. It's a fact of life. There's not a matter of whether CPAP mask is going to leak. It's a matter of what degree. And you know how they determine whether the leak is satisfactory? As long as they can maintain enough pressure to have an adequate therapeutic response, then that leak is acceptable. So it's not whether they got rid of the leak that's the determining factor. So we know that if somebody is positive for COVID, it's going to be aerosoled out. What we don't know is the implications of that, but we know that it happens. Then there's the other factor, that it's just ease of disinfection. We know how simple it is to disinfect an appliance, right? By just dropping it into a glass with a disinfectant, as opposed to disinfecting the machine and the hose and the mask. I mean, even under normal circumstances, that's laborious and people don't always adhere to it the way they should. So under these circumstances, maybe that's a concern. I don't know. Out of the paper published by the American Academy of Dental Sleep Medicine, oral appliance therapy is an effective treatment for OSA without increased risk for transmitting COVID-19. Patients who prefer oral appliance therapy may be more likely to adhere to treatment if they are confident that their therapy is not putting those in their household at an increased risk for COVID-19 exposure. So, PAP, it works. There's no question. Lots of evidence of that in the literature. We know it works. However, after 6 months, about 50% compliance, and after 5 years, 17% compliance. Okay, so we have highly effective in eliminating apnea, but moderate compliance. And there's the dose-dependent effect. Okay, 6 hours is needed to resolve objective measurements of sleepiness. 5.6 hours is needed to resolve objective hypertension. 6 hours is the threshold where mortality risk reduction is observed. So no wonder the 3.3 hours they had with the McAvoy study didn't really demonstrate a difference. Okay. Yet, we look at the 5.66, and we know that 4 hours is the threshold that they consider compliant, well below the amount that's been established as being needed to resolve these medical issues. Now, oral appliances, of course, the effectiveness, looking at it from the point of view of reducing the apnea, is all over the map. And, the higher up the severity, it reduces the likelihood that you're going to get all the way down. Not that it won't work, it just may not work, but we know that compliance is very high, whether it's measured subjectively or measured objectively. You're up around the 90% mark. Okay, so oral appliance, moderately effective in eliminating apnea, but high long-term compliance, high hours per night usage. So this takes us to Van der Vegen's mean disease alleviation that he demonstrated in 2013. You know, he finally had an objective chip that they could put in an appliance in the mouth and get real data to do with compliance. And so once they could do that, they can actually officially calculate mean disease alleviation. So this is great. Wow, mean disease alleviation, with that taking into consideration both how long the patient's wearing the device, along with how effective it is at reducing the apnea, 50% approximately for both. No wonder the health outcomes, the health benefits are similar. Now, side effects. Let's just talk about that for a moment, because physicians are still quick to throw oral appliances under the bus for side effects, right? Well, you know, they're going to mess up your jaw, and, you know, some patients can't tolerate wearing them, and, you know, this stuff, this first things that I hear come out of their mouth sometimes when speaking to me for the first time, not the second time. Oral appliances and PAP, similar intensity and frequency of side effects, right? Reported side effects were similar in frequency and intensity. Oral appliance therapy was preferred by greater than 70% of patients. This was published back in 2009. It's not new information. Okay. Now, if we look at the paper that the ABDSM put out just a couple of years ago, most common issue is transient morning jaw pain, watchful waiting, palliative care, isometric contraction, and passive jaw exercise, and decreasing the titration rate are all considered first-line treatments to manage these initial transient jaw discomforts, right? Minor transient initial discomforts, no limitations or impairment. Okay, after 2 to 3 months, discomforts drop to baseline. Pre-existing TMD is not a reason to contraindicate oral appliance therapy for OSA, and possible therapeutic effect on TMD. Weak evidence on this, but yeah, there's suggestions in different papers that they seem to see improvements in pre-existing, you know, temporomandibular issues. So TMD symptoms decrease with oral appliance therapy, mentioned a number of times in the literature. For pre-existing TMD, there's no exacerbation, it's clear, and possible decrease in symptoms over time. Let's look at CPAP versus oral appliance therapy from a conceptualized perspective, right? Different categories. You know, oral appliance is blue and CPAP is red. So polysomnographic efficacy, the ability to be able to reduce the apnea down below 5. Well, CPAP wins every day of the week, okay? However, symptom control, similar. Health benefits, similar. Adherence, oral appliance wins. Tolerance, oral appliance wins. Patient and partner acceptance, oral appliance wins. Convenience, oral appliance wins. Affordability, that depends on your jurisdiction and insurance coverage and so forth. The actual cost of providing the therapy is similar, but the cost of the patient is going to vary depending on where they live. Then you get back to polysomnographic evidence. So efficacy. So I guess you could say the proof is in the pudding, right? And the proof of the pudding is in the eating, is the way that the saying really goes. And we've been eating oral appliance pudding for 35 years, right? Since the mid-80s, right? If efficacy or side effects were problematic, oral appliance therapy would not demonstrate a 90% long-term compliance with patients wearing it 7.5 hours a night. Now, that's just an anecdotal, that's my opinion. I'm saying, like, you know, when you go down the street and you're wondering if a restaurant is any good, I mean, can you tell by looking at how many cars are in the parking lot whether that restaurant might be worth attending? Of course. Right? The patients have voted. Adherence is high because patients actually can tolerate wearing appliances, enjoy wearing appliances, at least from the perspective of the benefit they're getting for whatever nuisance it is to wear this thing every night. We can't say the same about CPAP. The numbers are very different, with really only about 1/3 of patients wearing their CPAP all night long, 1/3 wearing it part of the night and struggling and taking it off at some point, and 1/3 not wearing it altogether. Okay. So we get to the mean disease alleviation again. What do we do? With the Achilles heel for CPAP is compliance. So what do you do? Well, try a different mask. Yeah, I can't tell you how many times I've heard from patients, they've gone through 4 or 5 masks before they're finally coming to see me, for the possibility of an oral appliance, right? Humidification, well, that may up the game and make it a little bit more comfortable for some patient. Reduce the pressure. Well, now what you're doing is also reducing efficacy. So reduce the pressure, they can tolerate it better, but now they've got some residual apnea going. Just pointing that out. Okay, auto or BiPAP, and for some patients, they might find it more comfortable to go to one of the machines that ramp the pressure up and down. I don't think that it's been demonstrated that it makes a big difference, but on a one-off for a patient, that may be what it takes. Okay, for oral appliances, what do we do? Well, we can always try advancing some more. One of the things with your position is that whatever they topped out at, is this the max they can go? With passage of time, it's an adaptive thing. They can actually go further. And so perhaps 2 months, 3 months, 4 months down the road, they can actually wear it in a position that may be more effective. You can consider vertical. I phenotype my bites right from the get-go using Dan Lewandowski's method about, related to basically obesity. And so I try and do that up front. But if you haven't taken vertical into consideration, perhaps that's another tool that you can pull out. Positional therapy. You can use adjunctively positional therapy along with your appliance. Weight loss. Combination therapy, pulling out their PAP machine and using it along with their appliance. Lifestyle changes that basically create a healthier individual, even fitter without losing weight will make things better. Various surgeries that are available. Tongue muscle tone. There's a new device available in North America where they basically are electrocuting the tongue through a little therapy session every day. And, it actually changes the physiology of the muscle fibers and improves muscle function. And the only study on it right now is in mild sleep apneics, and it demonstrates a reduction in the problem. So maybe used adjunctively, is promising. They have a study going on right now with more severe sleep apnea, so we'll see what the outcome of that is there. And then myofunctional therapy, used adjunctively, right? There could be some benefit. Now, we're talking about what are things that are available to us when the appliance alone doesn't do the full job of eliminating the apnea. Okay? So the appliance can be either the full journey or it may be just the start of the journey to wellness. Okay? Let's just talk about some of these therapies. I pulled out some of the interesting ones. Position. Well, 1991, when this was first done by Cartwright with a tongue retaining device, demonstrating that positioning along with the tongue retaining device, up the game. And I love it here in 2015, a promising concept of combination therapy for positional obstructive sleep apnea, as if it's new. No, we've known about it since 91, right? Look at this baseline. You go to oral appliance alone, positional therapy alone, and combined. So you can see the improvements there. So whenever you're working with a patient that obviously has some residual supine apnea, doesn't it make sense to teach them about positional aids to help them stay off their back, along with wearing their appliance? This is a little pilot study done on CPAP patients that couldn't tolerate wearing their CPAP. So they had an appliance made, and they had incomplete resolution of their apnea. So what they did is they asked them to wear them both together. And you can see that the CPAP pressure was reduced from 9.4 down to 7.3. The residual apnea went from 11.2 down to 3.4. So 11.2 was the oral appliance alone, and 3.4 was CPAP plus the oral appliance. Oxygen desaturation, daytime sleepiness reduced. But the most interesting finding to me was that all 10 people tolerated the combination therapy. So in essence, what they did is they took 10 CPAP non-compliant patients, added an oral appliance, and turned them into 10 CPAP compliant patients, potentially, because they could tolerate wearing it. Okay? How often is that done or even considered? Now, this was published 2018, Additive effect of PAP and oral appliance therapy. Seeing pre-treatment here, PAP, of course, gets the number right down. Oral appliances, you're all over the map. You got some people, you got a little bit of help, other people that get down into pretty well the normal range. And then combining both together. So combining oral appliance with the CPAP resulted in the best outcome. Nasal resistance and BMI are the most important predictive factors for oral appliance outcomes. So higher nasal resistance may reduce oral appliance outcomes. Something to keep an eye on. Another thing, nasal patency issues actually, impact on your ability to be able to tolerate CPAP. So normalizing nasal patency will definitely help patients, comply with CPAP. Weight loss. This was interesting. A 10% weight gain predicted an approximately 32% increase in AHI, and a 10% weight loss predicted a 26% decrease in AHI. So as adjunctive therapy, you can see the value here. Off of the Sleep Foundation website, weight loss of just 10 to 15% can reduce the severity of OSA by 50% in moderately obese patients. Okay, so used adjunctively, weight loss along with their appliance. Interesting here, talks about exercise, even in the absence of weight loss, resulting in a reduction in disease severity. Once again, adjunctively, along with using an oral appliance. Myofunctional therapy, decrease apnea hypopnea index in approximately 50% of adults and 62% in children. Severe may serve as an adjunctive to other obstructive sleep apnea treatments. Now, one of the issues with myofunctional therapy is compliance and patient actually sticking with it and doing it. I'm not saying all of these are easy to do. Weight loss is not easy to do. I've struggled with weight my entire adult life. So, I understand this, so none of these things are easy, or they probably wouldn't exist in the first place, but it gives you something to work with. Okay. If you want the no-brainer, throw a mask on. They'll find a pressure. You can blow your toenails off if you want. They'll be able to keep that thing open. That airway will stay open. That's the no-brainer approach. But if you can't tolerate wearing CPAP and you want to work with an oral appliance, you're going to be able to bring some people down all the way. And for others, we're going to look for other things that we can use, other tools that we can use along with the appliance to get them down all the way. Something as simple as bed elevation. This is just 15 centimeters. It's not very much. Right? Look at the HI went from overall from 16 down to 11. Didn't eliminate it, but it's going to contribute in a positive manner. Supine HI went from 21 to 11. That's a big difference. Non-supine 12 to 8. Okay. And this is the neuromuscular stimulation device that I was mentioning earlier. We can see a 47% reduction in AHI, 41% reduction in ODI, 43% reduction in the upper sleepiness scale. So we're not talking about elimination of the problem here, but adjunctively, this may help. And it's a very simple device to use. It's used during the day. There's a time period where you're doing a daily treatment, and I think it's after about 3 weeks, you just go into a weekly type of regimen. Okay. So let's look at CPAP versus oral appliance therapy using the SomnoMed effectiveness equation. This is a software product that takes into consideration both how well the therapy is reducing the apnea, along with the length of time the patient wore the therapy through the night. So case number 1 here, baseline is 27.6, treated on CPAP down to 4.5, right? The appliance down to 12.5. So in any office, this would be considered, well, borderline, you're into the mild area here. I'm not really happy with this. But this is the best we can do. This is the best we can do. Some physicians say, well, I know the physicians I typically work with would say the appliance is not working. That's what they would tell the patient. Interesting. If the patient can tolerate their PAP 5 hours, but they can tolerate their oral appliance 7.5 hours, the global number of events all night long with the PAP is 105, and with the Somnodent or their oral appliance is 107. I would say these are the same number. And no wonder the medical outcomes are similar. So what would you do? Further adjustment, adjunctive therapies like we just discussed. Okay. Let's look at case number 2. The CPAP baseline 49.2 with CPAP 4 events per hour. Great job. The appliance not so great. 49 down to 27.5. And let's say they were able to wear their CPAP 3.5 hours per night versus 7.5 hours with their oral appliance. Okay. Total number of apneas through the night were 235 with CPAP, 230 with the oral appliance. Yet this appliance would be dismissed as being ineffective. Now, of course, we don't use that as an excuse not to bother with trying to get that number down further. We still look at the adjunctive therapies to try and do a better job. So let's look at case number 3. 99 events per hour at baseline down to 3.9. Fabulous job. Oral appliance fell short at 27.9 once again. 5.5 hours a night with their CPAP. That's pretty darn good considering 4 hours minimum is a minimum expectation for compliance. 7.5 hours with their oral appliance. 268 events globally for the night with on CPAP. 258 with the oral appliance. Now we're looking at an appliance that's sitting at 27.9, but overall globally for the evening, it was only 10 apneic events different. I'm going to say once again, no wonder the medical outcomes are so similar. Okay. Final example, 119 events per hour. I'm getting braver here, down to 3 events per hour. Now, oral appliance only got them down to 29. They're wearing it 4.5 hours a night CPAP, which is over 4 hours, so they're deemed compliant. They're wearing their appliance 7.5 hours per night. 430 events on their the CPAP patient globally for the night, 277 for the appliance patient. Wait a second. First of all, many physicians don't even think we should be using an appliance on somebody that's got 119 events per hour. And look, it only got it down to 29. This is a failure. Really? 430 events on CPAP wearing 4.5 hours. They're deemed compliant versus 277 on the appliance. That leaves me even bewildered every time I see that slide. So there's an optics thing going on here. We have a third of patients that can wear their CPAP all night, every night. Everybody's happy, including the patient. We have a third of patients that struggle with their CPAP and they take it off partway through the night. They just can't make it through the whole night. And then we have a third of patients that just can't deal with it at all. Anecdotally, that number, and I've stated those numbers in front of a room full of sleep physicians at sleep rounds, no one's ever challenged me. Everybody buys that that's approximately what's happening. MD optics, we're taking care of 2/3 of the patients. The first third wear it all night long. The second third, they're getting some help, right? And by the way, those statistics are much better than the typical adherence we get from prescriptions that are written in medicine. So little pat on the back, we're doing great. Those of us that are in dental sleep medicine, so wait a second, you're messing it up with 2/3 of the patients. There's a third that can't wear your appliance at all. And there's a third that are only wearing it part of the night and clearly below the threshold where they're getting this, they're not getting the medical benefit that you're hoping for. So, the way you look at this problem is going to determine your position. So we have an optics problem, but there's actually more. Is it even really about AHI reduction? Okay, by now, I think probably all of you have seen this paper on the rise and fall of apnea-hypopnea index, a historical review and critical appraisal. Okay, some quotes right out of the paper because I can't say it any better. The AHI is based on assumptions that it represents a disease state of OSA and that clinical manifestations are invariably caused by OSA if the AHI is above a diagnostic threshold. Critical appraisal of extensive literature shows both assumptions are invalid. This conclusion prompts a reconsideration of the role of AHI as the prime diagnostic metric of clinically relevant OSA. We believe it is time to release AHI as a mainstay for the OSA diagnosis and to start using more precise clinical markers, many of which still remain to be discovered. Clearly above our pay grade, we as dentists are not going to be making any of these decisions or changes, but this is the current thinking and the way the literature is discussing this now. But there's more. Before coining the term apnea index in 1978, Guillemot and his buddies, they actually looked at things differently. At that time, they actually preferred reporting the total number of events through the night, similar to what we were just talking about, or total duration of nocturnal apneas rather than a number per hour of sleep. At some point, they made a decision to term the apnea index on an hourly basis when they published that in 1978. So based on what we know now, based on the literature that's mounting, adherence, health outcomes, MDA, mean disease alleviation, had this alternative definition being coined in 1978, it was the global number of events every night that was being looked at, we may have had a very different perspective on the therapeutic effectiveness of oral appliance therapy all these years. We've had a hard ride because we've been held to a certain standard of, will you get that index down to below 5? So if the definition had been planted differently in the literature in 1978, it would have been a different experience. CPAP versus oral appliance therapy, which is better? Well, it depends on your optics. Obviously, AHI resolution, CPAP wins. Patient preference, oral appliance wins. Mean disease alleviation point of view, they're equal. Okay, the literature suggests this question can only be answered if also considering adherence to therapy. So the most important factor is which will the patient wear? Circling back to the question I had on the second slide. So just want to make you aware of our online learning platform, SDD Academy and .com. There's a ton of free content on there with regards to the Dental Sleep in 5 series. There's a whole bunch of By Corona webinars that we have posted with different speakers, including Barry Glassman that I saw earlier on tonight here. And then we have our Dental Sleep Medicine Speakeasy where we had open discussion about various topics, and there's free ebooks. So, you know, take the time to check out the website and see if there's anything there of interest to you. And so at this point, I'm available for questions. Let me just say the last thing. There's a Z Sleep Club, you know, a little special there, whatever. You know, check it out. But just check out the website in general and see if there's content there that's interesting to you. So I'm available for questions now, David.